Hello everyone, I am Beatrice. In today's video, we'll look at syndrome of inappropriate antidiuretic hormone, what we call SIADH. So this is part of endocrine review. This topic, together with diabetes insipidus, which I will look at in another video, is commonly tested in NCLEX, and students can easily mistake these two topics together. They can mistake these two conditions. So try and pay proper attention as we review this topic. I will highlight some points you may likely see in your exams. And also, before the end of this video, there will be a quiz that will test your knowledge of this topic. So if you are ready for today's video, let's dive in. SIADH is a condition where the body produces excessive amount of antidiuretic hormone, what we call vasopressin. Or in other words, we say there's inappropriate production or secretion of this antidiuretic hormone. Antidiuretic hormone itself is produced in response to low blood volume. You see the name antidiuretic hormone, so it's against diuretics. So in other words, it's produced in response to, let's say, condition like low blood pressure, or there's low blood volume, or if somebody is dehydrated, or there's high osmolality of the blood where the blood is so concentrated. So it's secreted so that it can help the kidney to reabsorb fluid back, because when fluid is retained and reabsorbed back, it will lead to increased pressure, it will increase blood volume, it will fix that dehydration, and then it will fix that high osmolality of the blood by diluting the blood and reduce that viscosity of the blood. But in a situation whereby this hormone, antidiuretic hormone, is over-secreted, it begins to do the work too much. Now, what will happen is that even when the person is not dehydrated, it's still retaining fluid, and that will lead to what? Fluid volume excess. That's a major nursing diagnosis. The person is going to experience fluid overload. The person will retain fluid a lot. So now, what can cause this condition, SIADH? One of them is cancer or brain tumor, and then at times trauma like head injury can also trigger that. Then stroke and meningitis, and then surgery or effect of anesthesia can also cause this. And then also some medications like SSRI, selective serotonin reuptake inhibitors, like carbamazepine, opioids, can at times trigger this condition. Now, the pathophysiology of SIADH is simple. It's just what I've explained before now. First, there's increased production of antidiuretic hormone. Inappropriate production is produced in excess, and that will lead to the kidney reabsorbing too much water, even if the person is overhydrated. And of course, that will lead to fluid overload or fluid volume excess. And with that, there's going to be dilutional hyponatremia. That means the sodium in the blood is going to get too diluted, and that can be a problem. It can cause neurological changes. And then finally, there will be low serum osmolality. That means the blood is going to be also very diluted. Now, let's look at the symptoms of SIADH. Now, the biggest danger is neurological symptoms. Of course, with low sodium in the blood, hyponatremia, because of that excessive dilution, or even excessive fluid retention in the body, which can cause cerebral edema, the patient stands the risk of neurological symptoms. Another thing you need to know is that the patient is going to produce very small amount of urine. The urine will be so concentrated. Why? Because the patient is keeping too many fluids, so a little urine is produced. And then tachycardia, hypertension, jugular vein distension. Of course, with a patient retaining so much fluid inside there, it's going to increase blood volume, and that will mean increased blood pressure. So the patient stands the risk of hypertension. And then with that retention of fluid, you could notice jugular vein distension. And another thing is crackles. Because of that excessive fluid overload, it can cause pulmonary edema. And when you auscultate the lungs, you could hear crackles. Then weight gain, of course, because of that fluid retention. And then the patient will experience muscle cramps. The biggest danger is neurological symptoms. And that's due to that hyponatremia, where the sodium becomes low. The normal range of sodium is 135 to 145 milliequivalent per liter. But in a situation where the patient is having low sodium, below that 135 milliequivalent per liter, or very low sodium, it can cause problem with neurology, with the brain and everything. And it's also linked to cerebral edema. Some of the neurological symptoms you may notice in a patient with SIADH may include things like headache, vomiting, irritability, confusion, seizures, lethargy. Now, the nursing diagnosis you should take note of that you may see in a question is fluid volume excess or fluid volume overload. Let's look at the laboratory findings and diagnosis. For a patient with SIADH, first, the urine is going to be so concentrated, the patient is producing just little urine. Another thing is there will be increased urine osmolality. That means urine is actually very concentrated. And then we have increased urine specific gravity. Now, the normal urine specific gravity range is from 1.005 to 1.030. But in SIADH, it's going to be so high, it will be greater than 1.030. Then we have low serum osmolality. That means the serum is going to be very, very dilute because of that excessive fluid. It will be less than 280 milliosmol per kilogram. Now, let's look at the treatment, nursing intervention, patient education. The aim is to restore normal fluid volume. Those excessive fluid that is stored in there, we want to get rid of some of them so that we can maintain balance and maintain osmolality. And that means there will be what? Fluid restriction. So we need to restrict the patient of fluids because they have a lot of fluid. So this is not the one you encourage to drink fluid. They are already overhydrated. So diuretics, like especially loop diuretics like furosemide, can be administered to the patient to help remove some of those fluids, to challenge the kidney to push out some of those fluids. But you need to know that diuretics, especially loop diuretics, can cause hyponatremia, can also make the patient to now lose further sodium. And remember, they already have dilutional hyponatremia. The sodium in the blood is already low because of overdilution. Now, when they are giving diuretics, so you need to monitor that sodium level closely so that they don't lose too much of it again. And also, diuretics also promote excretion of potassium. So you need to watch out also for hypokalemia. Now we have vasopressin receptor antagonists. Remember, another name for vasopressin is antidiuretic hormone. So this one is going to act as a receptor antagonist. It's going to block the action of antidiuretic hormone so that it's not able to reabsorb water back. An example is tolvaptan. Now another one is diclomycin. This medication is a tetracycline group of antibiotics. The role is to act on the kidney. It causes renal resistance to that antidiuretic hormone so that the antidiuretic hormone is not able to work effectively on the kidney to reabsorb fluid back. But you need to teach the patient taking diclomycin to avoid any calcium containing food like yogurt, milk. Also teach them not to take it with antacid, especially calcium containing antacid. The reason is because calcium causes decreased absorption of the medication. In severe hyponatremia, the patient may be given hypertonic saline. Now, one of the reasons why hypertonic solution is administered is to increase that sodium in the blood to correct the hyponatremia. But you have to administer it cautiously. Another thing is that by osmosis, fluid is going to move from intracellular to extracellular. So it's going to help pull out some of those fluids. But you also need to watch out because as the fluid moves a lot, it may cause what we call pulmonary edema. The fluid may get to a point where it can get to the lung. So when you're administering hypertonic solution, you're also careful with that so that you don't overpool the fluid. So you administer it cautiously. And finally, you need to monitor intake and output, daily weight, and neurological assessment. Very, very important. So in summary, SIADH has to do with inappropriate secretion of antidiuretic hormone, leading to excessive fluid accumulation, what we call fluid volume overload or fluid volume excess. So your nursing intervention, which is also centered around NCLEX question, has to do with you restricting fluids. That's not the time to encourage patients to start drinking fluid, and getting rid of water through use of diuretics and diclomycin, and also correcting sodium cautiously. Now let's review some NCLEX-style questions that will test your knowledge on SIADH. Question 1. A client with suspected SIADH is admitted. Which laboratory finding would the nurse expect? A. Serum sodium of 148 milliequivalent per liter, urine specific gravity of 1.002. B. Serum sodium 120 milliequivalent per liter, urine specific gravity greater than 1.030. C. Serum sodium 140 milliequivalent per liter, urine specific gravity 1.005. D. Serum sodium 138 milliequivalent per liter, urine specific gravity 1.010. The best answer will be B. That's serum sodium of 120 milliequivalent per liter and urine specific gravity greater than 1.030. The reason is because SIADH causes water retention. So it leads to dilutional hyponatremia. Therefore, the sodium will be low. It will be below that 135. So that 120 is correct. And the urine is going to be concentrated because they will not excrete a lot of urine. So the specific gravity will be greater than 1.030. Question 2. A nurse is caring for a patient with SIADH. Which intervention is a priority? A. Encourage oral fluids up to 3 liters per day. B. Administer desmopressin as ordered. C. Restrict fluid to 800 to 1000 ml per day. And D. Administer large doses of IV normal saline rapidly. The best answer would be C. Restrict fluids to 800 to 1000 ml per day. We know that the first line treatment of SIADH is fluid restriction, so you have to restrict fluid. That's not the time to start giving fluid. And that desmopressin is used in diabetes insipidus, not in SIADH. Question 3. Which clinical findings should allow the nurse to worsen SIADH? A. Increased thirst and dry mucous membrane. B. Weight loss and polyuria. C. Confusion and seizure activity. D. Decreased urine specific gravity. The best answer will be C, which is confusion and seizure activity. So in severe hyponatremia from SIADH can cause neurological complications like confusion, seizures, and all that. Question 4, which is the last question. A patient with SIADH is being treated with hypertonic saline. What is the most important nursing action? A. Correct sodium by more than 12 milli equivalent per liter in the first 24 hours. B. Monitor closely for pulmonary edema and neurological changes. C. Encourage free water intake with hypertonic saline. D. Administer desmopressin with the IV infusion. The best answer will be B. Monitor closely for pulmonary edema and neurological changes. So that wraps us today's topic on SIADH. If you find this video helpful, please like this video, share this video with others that may benefit from it, and also leave your comment and subscribe for more educational videos. Thanks for watching.